Welcome to Holistic Health 1031. Today the concept we're going to be discussing is perfusion. Throughout this there's going to be obviously voiceover, and then there's also going to be some questions and videos for you to watch. So everybody's written down their definitions of perfusion. Here is Giddens' definition. It's the flow of blood through arteries and capillaries, delivering nutrients and oxygen to cells and removing cellular waste products. This becomes really important as we discuss our exemplars, because that delivering nutrients part starts to think about why we have some of the complications we have, along with the oxygenation, which we all already know is obviously important for sustaining life and growth. So here we're going to talk about some related terms. We're going to talk about ischemia and anoxia. And while they're very similar, there are some differences. Ischemia is inadequate blood flow. Okay, so this is meaning that the blood is not getting to where it needs to, while anoxia is more the deficiency of O2. So ischemia eventually leads to anoxia, because if you're not getting enough blood flow, you will decrease your O2 that's getting to that tissue. So any cardiac nurse you talk to thinks they are all that in a bag of chips, because if the heart is not pumping correctly, your tissue is lacking oxygen, you can't think, you can't be an effective human being, and your survivability is going to be really poor. But here we're going to talk about some central perfusion and tissue perfusion. So impairment of central perfusion occurs when cardiac output is inadequate. Reduced cardiac output, so the volume of your heart is pushing out, results in reduction of oxygenated blood reaching the body tissues, and it is a systemic effect. So if you think of your heart as just a glorified pump, if it is not working effectively, if this heart isn't working effectively, none of this tissue where these capillaries are is going to get adequate blood flow, adequate oxygen, and adequate nutrients. So let's talk about some risk factors for this and the populations that are at greatest risk. This lecture is over congenital problems. So which population is at greatest risk? Well, it doesn't really matter your age, and it doesn't really matter your gender, and it really doesn't matter your race. Everyone is at risk for having congenital heart defects, okay? Your socioeconomic status doesn't matter, although it can affect it greatly. Your size doesn't matter, although then again it can affect it greatly, and the outcomes greatly, but really everybody is at risk for congenital heart defects and heart problems. Individual risk factors for congenital heart disease. They're the most common type of birth defect. They occur 8 out of 1,000 births. 50% of these infants show signs and symptoms within the first year of life. They can be caused by some genetic, maternal, or environmental factors. But again, it's the most common type of birth defect. It's not a problem for the fetus when they're inside of mom because of the fetal maternal circulation, but at birth the infant circulatory system must take over and provide the child's oxygen needs, and this is when we start to have a lot of problems with our congenital heart defects. So the etiology and pathophysiology. There's 2 classifications of congenital defects. You have acyanotic, which A in Latin is without, and cyanotic, it got that blue color, so this is without blue. So they have no blue coloring and normal oxygen levels in their blood. And then you have your cyanotic defects, which then cause the blue coloring of skin, and the defects result in low oxygen and blood levels. So you can see in this picture, you can see that we've got a kiddo that's got some blue toes, blue hands, and then that blue lips. And every once in a while, you guys, you will genuinely walk into a room and look at someone and be like, oh my goodness, they are literally blue. So we always have to pay attention to what's going on with them that would cause those kinds of issues. So we're going to do a nursing assessment history for someone that is getting diagnosed with congenital heart defect. Now, a lot of times, because ultrasounds are so amazing and so many people get them now, we're going to have this diagnosis before even delivery happens, because they're going to have an ultrasound at a really young time in the pregnancy. And so a lot of times you're going to see these kinds of things, especially if they're structural in nature, we'll see them. So this is going to be a young mom that's pregnant, and so we have to be careful at how we're saying this, because while drug and alcohol use and rubella illness and all these other things might be a cause, they're only 2% of the causes of this, okay? So you got to be real careful about how you're going to ask these questions. Then we have the genetic issues that can happen that can cause, but again, that's only 10%. 88% of these defects are unknown causes. So just be really careful if you're working in a clinic or an office and you've got a mom who's getting told that her baby has a congenital heart defect, that we're not jumping straight to the drugs and alcohol. While that sometimes can be an issue, it for the majority of the time is not. So always be careful when we're talking and educating people on these kinds of defects. So our congenital heart defects, again, we're mainly talking about young-aged children. This little guy, I would not say has an actual heart defect, although he is a nice little model for us. Things that we're gonna make sure we assess, obviously, are pulse, and I would check pulse not only in one spot, but you would want to check it in a couple spots and to see how they compare in each spot, because that's gonna differ. Femoral is a really great place to always check. Along with on kiddos, we're going to want to check in that brachial spot. So we're going to want to check pulses in lots of different areas. We're also going to want to listen to our heart, right? We're going to get that apical sound, and you're going to listen down around your borders of the heart in your different spots, okay? So we really want to assess how that heart sounds, because it'll have different sounds depending on the congenital defect. Chest walls are thin in infants and young children because of relative lack of subcutaneous muscle tissue compared to older children. So this kiddo is obviously not missing too much subcutaneous tissue. So you're talking more your young kids, especially kiddos that have congenital heart defects, because remember that transference of nutrients, they don't have that as well. Newborn circulation differs from fetal, because remember, when they're in the womb, they're taking and getting some of mom's blood, or mom's helping with that, so they aren't doing as much on their own, and we really have to pay attention to that. Capillary function is immature in newborns. It takes several weeks for those small capillaries to expand and contract in response to external temperatures, putting them at risk for what? Putting them at risk for heat and cold variations. They can't regulate their temperatures. That's why we have to make sure that we put kiddos in heat, in the incubators and stuff like that, or that skin-to-skin contact for that temperature regulation. Heart rate is higher in newborns, okay? So this one we get really sticky, because you guys have really probably focused a lot on the adult the adult vital signs, and so we really have to pay attention to what they are in newborns, infants, and then adults. And even infants, then you go toddlers and young adults. I mean, it's very variable throughout the entire time. Children have limited ability to increase stroke volume in response to decreased cardiac output. So we need to really pay attention. They don't have that ability to accommodate quickly as we do as we get older. And most heart conditions in children result from defects in an embryonic structure. So that means while they're in the womb, this happens. So again, if they've had an ultrasound, if mom had prenatal care, we probably are going to know most of the cardiac defects, but that's not to say you don't get a mom that doesn't know because either it wasn't seen or she didn't have prenatal care. So inadequate central perfusion in infants and children. Signs and symptoms. In infants, poor feeding. Now, why would it be poor feeding? It's not their stomach that's involved, correct? Well, think about what's happening. They are getting decreased O2. So if they're getting decreased O2, what do you have to do in order to eat? You have to stop breathing in order to swallow. Otherwise, everything would go in our lungs. When we stop breathing to take that second or two to swallow, we decrease our oxygen. If we're already starting out with a low O2, we then are having a problem with oxygenation because of the cardiac issues. So if we have then poor nutrition or poor feeding, we then have poor weight gain and failure to thrive. So both of these things come from this. All right, and then we have the dusky color that happens, and that's again from that low O2. So while we know that this is a perfusion issue, right, because the pump isn't working, it's the oxygenation and then the nutrients that we then have the problems and the signs and symptoms from the perfusion problem. With toddlers and children, if you see them, they're going to do this like weird stance where they squat down, okay? And what they're doing is they're shunting that blood flow back up. Okay, they're squatting down. They learn to do this at a really early age because when they squat down, it makes them feel better. They feel like they have that increased oxygenation because they're getting that blood flow back to the brain, the heart, and the lungs where they really need it. They don't feel like they need blood flow in their feet very well. And then they're going to get fatigued. Again, they're going to get that fatigue because they also will have poor weight gain, poor feeding, and that failure to thrive, which then hits the developmental delays and the failures to hit milestones. All right, so you might have a kiddo that comes into your clinic and they're just not quite where they should be developmentally, and they're not hitting those milestones, and you're wondering why, and then they're sitting in the corner squatting, and mom and dad just don't have a clue what's going on, and we listen to their chest and their heart, and we're like, oh, there's something not right here. Okay, so we have to really do good assessments on these kids. Some more signs and symptoms that they also might have. Hopefully these ones would get them into the doctor sooner. Is that cyanosis? So remember, cyan is that blue color. Their pallor might be really pale or dusky kind of color, grayish. They might be breathing really fast or have difficulty breathing because, again, they're having decreased O2 from the inability to perfuse appropriately. They might have pulsations in their necks as their vessels are trying to fix, and then clubbing fingers, which they get from the lack of oxygen coming to their fingertips. So they kind of have bulbous tips to their fingernails and to their nail beds, and then they might be kind of blue around in here as well. And so that's when you know that something's going on, right? So as we continue with nursing assessment, we're going to talk about some diagnostic tests. And you guys should be pretty familiar at this point in time with radiographic studies. We've got the chest X-ray where we're going to look and see if that heart is enlarged. Okay, in there we'll see through shadowing and stuff like that because there aren't any bones in your heart, but there are densities and stuff like that and sizes that we can see. They might do an ultrasound depending if this is a mom who has had the baby, then they might do an ultrasound of the heart, or they might do an ultrasound of the mom looking at the baby's heart to see what's going on. And then our arteriogram is where they put some contrast in there and they look at the vessels to see how they're flowing. Another thing we can do is an electrocardiogram or an ECG, which frequently people call EKGs, but it is an ECG. So just more challenging to say. It shows the electrical activity of the heart. It's going to show your P wave, your QRST waves, okay? And this is the cycle, definitely not drawn like that. But this is the cycle of the heart that we want. And what happens is as that electricity has a hard time passing through the heart. So if you imagine this being your heart with the different chambers and all that, and then you have your electricity passing through, this is the wave or something similar that you'll get. Okay, but as the heart is deformed or having problems, that wave can change. And so ECGs are a very non-invasive way to look and see if that heart is, the electrical activity of the heart is correct. An echocardiogram then is when we actually do an ultrasound of the heart. It's going to show us the any dysfunctions that are going on in the heart, different pump, how it's pumping, if there's backflow of the blood, they can see any of that kind of stuff. It visualizes the internal heart structures. So this is where we're actually going to get to see what's going on inside that heart and inside that chest cavity. All right, lab values are hugely important when it comes to cardiacs. Dysfunctions. So cardiac markers are released when the heart cells die. So when that cardiac muscle or the heart cells start dying, we have cardiac markers. CPK, okay, I mean it's this nice big long name, but we call it CPK, is an enzyme that's found in the brain, heart, and skeletal muscles. It elevates at about 4 to 8 hours after there's been an MI, but also any injury to the heart. Okay, CKMB is elevates within 4 to 6 hours after injury to the heart, and peaks in about 12 to 24 hours. But this one, CKMB, this one is specific to that cardiac muscle. All right, just specific to the heart muscle. Then you have your troponin, okay, which down here, which again is specific to the cardiac muscle damage, and it will rise within about 4 to 6 hours as well after damage. Okay, so you'll see an elevation in those numbers, and they won't; those numbers don't stay high forever. They just kind of show the initial damage, and then they decrease again or go back to normal. The BNP, okay, this one is a cardiac hormone that's released with ventricular dilation or stretching. It occurs when we see heart failure. So when you get a BNP that's over 100, that means we're running into trouble. That is an abnormal finding, and it means that we're going to be starting to get into some heart failure. I think the highest I've ever seen is about 3,200, and that person was not doing so hot. So we have to make sure that with that BNP, anything over 100 means that we're getting into some heart failure issues. Right? We've got the CRP, which is C-reactive protein. This identifies inflammation in the body, and it can be anywhere. That's why this one, they used to use it a lot, and now it's kind of going out of favor because it really just shows inflammation in the body when you can have inflammation in lots of spots. But if you have someone that is in, you know, like their BNP is elevated and their troponin's elevated and stuff like that, it's just another sign to show that inflammation is climbing. Then we have your serum lipids, your LDL, which you want low, and your HDLs, which you want high, and all the other things, the lipids that are in your lipid panel. Your PT is going to show us some clotting time. Okay, PT-INR are used to adjust your Coumadin. So this is one that we're going to use to adjust our Coumadin. Okay. And then your PTT is one that we use to adjust a heparin drip, which is what a lot of these kiddos are going to be on until they can get their heart repaired, because clots kill us. when we get clots in the heart, that's what sends them to the brain, and we have massive strokes, or we send clots to the lungs, and that's what kills us. So we have to make sure that the heart is perfusing efficiently enough that clots don't build up, and so then we have a lot of kiddos that are going to be on a Coumadin therapy, maybe at home or long term, or a heparin therapy until we can get something fixed better for them. Primary prevention. Prenatal care, as we've talked about earlier, is probably key, although once this stuff has started to develop, it's really hard you can't stop it. So prenatal care is more for education on the mom that's going to have one of these kiddos, because they're going to have a more complicated hospital stay. They're not getting out of the hospital in 24 hours like other babies. So that prenatal care is super, super important for being prepared for these babies. And then, like we always do, we discuss with moms to avoid drugs and alcohol during pregnancy and that kind of stuff. But remember, that's only 2% or less of the reason that these things happen. So don't go heavy into this just because you're worried about a cardiac defect. That prenatal care, we have to also remember there's lots of reasons why women don't get prenatal care. Either it could be cultural, that they don't believe it's not a disease, so they don't get prenatal care. It can be financial. Okay. A lot of financial strains, especially with insurance changing and adjusting as it is right now. There's a lot of unsure in our insurance issues, and then, there can be just a lot of other reasons. You can have someone that's young and doesn't know. Okay, you always hear about those moms that don't know they're pregnant. A lot of times they're young. So, there's a lot of reasons people don't get prenatal care. It's not because they don't care about their baby. It's just they might have other things to worry about. They might be in denial about the pregnancy. Okay, you never know. So just be really careful to watch your judgment when you're doing primary prevention with moms, because there are a lot of reasons why people don't get prenatal care, and we tend to judge if you don't get prenatal care, what, you didn't care about your baby. Well, there may have been other issues that prevented them, or they just didn't see prenatal care as a need if it was cultural, because pregnancy is healthy and natural, and you don't need to go to the doctor for a natural process. So when we're talking about collaborative interventions, this is when we really want to get our pharmacist involved with us to help control this. Some cardiac glycosides, some antihypertensive, your ACE inhibitors, diuretics to get that fluid off. And then that oxygen is so important, because remember, they're having decreased O2. So we want to decrease that O2. We want to increase that perfusion of what's actually getting pushed around. So that's the reason why we do these medications, okay? Surgical interventions, we'll discuss specific surgical with each exemplar that we go through, because they all have a little bit different take on it. So the nursing interventions depend on how much and what's going on with your patient. Again, our goal is to increase that oxygenation and the perfusion, okay? Because of the decreased oxygen, we want to bump that back up. Educate parents and clients about, in general health. We want these people to avoid sports, the competitive sports, because they're not going to have a ton of energy. Maybe they can do things like swimming or something like that, but you're definitely not going to have them in football. We want hygiene to prevent infections. We want dental care. With dental care, something that's really important is this antibiotics before all dental procedures, because it prevents bacteremia, which leads to bacterial endocarditis. And I have seen bacterial endocarditis one time, and the girl did not do very well from it. Once that bacterial infection gets into that heart, it's really hard to get it out. So we need to make sure that all of our families who are taking care of one of these kids or taking care of themselves, they get antibiotics before they go to a dental cleaning or a procedure. Balanced diet. To prevent anemia, because of that decreased perfusion, they can have anemia. We're going to make sure that they eat some protein. We want to promote growth and development and to continue hit their milestones as much as possible. Routine immunizations, often avoided until after a heart transplant due to the anti-rejection therapy. But if the doctor says to get immunizations, we're going to give them to them. The problem for many congestive heart disease children who are living till adulthood is their parents are aware of all of this, but the children don't know or understand this basic preventative things. So when they become adults and start caring for themselves, they might slip back into I don't have to do this. Especially think of teenagers and how defiant they are. I'm not that sick. I can hang out with my friends. I can do what I want. So you have to think about this is across the lifespan. This is the whole lifespan from the kiddo that the parents are taking care of to the adolescent who's defiant and finding their own feet underneath them, and then the adult who can then again take care of themselves, but not always to the best, and then hopefully as they get older they can take better care of themselves. So this is something to help you think. Interrelated concepts, right? We don't just take care of one piece of a person. The person is the whole body. So we need to make sure when we're taking care of a person that we're taking care of the whole person, okay? And how the concepts affect the person and in each and every part of their life. So when we're talking about perfusion here, how does inflammation and mobility and cognition, how does any of that go with perfusion? Work on answering those questions. Use that as a study time or with your classmates to think about how the concepts interrelate to make the whole person cope with one type of issue. So when we're talking about these congenital heart defects, which is often just simplified as CHD, or changes in that perfusion, it's usually due to a couple things. It's due to changes in heart structure, changes in the arteries, or changes in both. So keep those three things in mind as we go through the different types of heart dysfunctions. Atrial septal defect is an abnormal opening between the right and left atria. So the atria are the top chambers, and it's that abnormal opening. So you can see that blood is shunting over, because remember, it's going to go from the area of less pressure or the area of most pressure to the area of less pressure. The opening allows oxygenated blood to be forced from the left atria back to the right atrium. So slowing down getting that oxygen in there. You can have the signs and symptoms of this. They can be asymptomatic. Remember, A means not and symptomatic, so no symptoms. All right. Or this might be the kiddo that you listen to and they have a murmur. All right. And so they're going to have that whoosh sound as you listen to them. So you're going to hear like the lub dub whoosh or whoosh lub dub. So somewhere there might be a whoosh sound in there, and that's that backflow of the blood. Diagnostic tests, they can do a cardiac catheterization, which is pretty invasive, but a lot of times you're going to start off with an ECG and an echocardiogram. Those are kind of your two non-invasive procedures that they're going to do, and then eventually they may need to get to that cardiac cath just to see how big that hole might be. If the atrial septal defect does not close on its own because the opening is big enough, then they might need a treatment, which is surgery, where they apply a patch over the opening or a closure over the opening piece. So they'll put in this little piece of kind of cloth patch, and it'll kind of, you can see that there's a back side and a front side, and it kind of closes over that hole, and then the body scars in it and builds up that tissue to help build in a wall where there wasn't one before. Somebody that had an atrial septal defect repair, they are going to be on that low dose aspirin, and they might be on it for like 6 months after the repair. And again, they're going to have several checks because they're going to be listening for that murmur. And you might have parents that start to get stethoscopes and listen for murmurs and stuff like that, depending on how active the parents are in that kind of wanting to know what's going on. But the aspirin is going to help to prevent the clots from forming on closure to decrease risk of PEs and stroke. So here is the most common heart anomaly. It is the ventricular septal defect. So this is a hole in the ventricular wall where it is a left to right shunt. So it's going to push from the left ventricle to the right because of the increased pressure in the left, which forces the blood back to the right and messes with that cardiac cycle. Okay. The symptoms are going to be a loud, harsh murmur. So this is going to be a much more evident murmur when you listen to them. Again, you're going to start with that non-invasive exam first, which is the echocardiogram. And of course, that's after they've gone, well, there's a murmur or something going on in there. And then they'll do a cardiac catheterization with probably a treatment in there to help patch that up. So our ventricular septal defect, again, it shows you kind of that hole that's in there. It can have a spontaneous closure. As the heart gets a little bit bigger, they might close on their own. The other thing they can do is kind of something similar to what they did, except this patch they might sew in place, because remember, our ventricular are muscular and have a lot more force to them. So they might have to do little stitches to sew this patch in. But they can do a cardiac cath to see what's going on, and then if they have to, they'll go in and do surgery to fix that area. Coarctation of the aorta is a narrowing or constriction of the aortic arch or descending aorta. So you can see in this picture here, you can see how there's that constricture right there in that aorta. So if you think about where do these blood vessels go, these blood vessels go to your arms, your heart, or your arms and your brain. So if you get something that's building up here, like a clot, this can be very dangerous because all of a sudden you've got a lot more pressure here, because think of a garden hose when you put your thumb on the end of it and you increase that pressure. This has more pressure, and all of these have more pressure as well. So they're putting a lot of pressure up there. So what do you think would be the sign and symptom? A marked difference in blood pressure between upper and lower extremities, because this isn't going to have as much volume. Even though there's a lot of pressure in that first push, by the time it gets down to the feet, there's not going to be a whole lot of volume giving into that blood pressure. So we have to make sure that we're checking that blood pressure. And then the pulses also. So remember when we talked about where all are we checking pulses on these kiddos, we're going to be checking them on the arms, but we're also going to be checking those pedal pulses. Okay, so then there might be some different coloring depending if it's at birth. There might be some different coloring of the feet and the hands as well. Hopefully the person had the mom had prenatal care, so she saw and knew that this was all coming. But if she didn't, a diagnostic test that is not invasive is that echocardiogram. So looking in there, looking at that heart and looking at the structures of it, and then they can see if there's some issues there. So with our coarctation of the aorta, if it's left untreated, some things that can happen is that hypertension can happen, CHF, so that congestive heart failure can start, or they can get an infective endocarditis may develop. So a lot of things can happen if we don't treat it. Treatments, they might go in with a percutaneous balloon angioplasty and kind of open up that, that part that's kind of constricted. Or they can go in and they can cut the two portions and then re-anastomose the areas. So it's just really going to depend. Treatment is very, very dependent on the type and severity of the defect. It may be something that they just watch for a while, or it may be something that they need to go in and fix very quickly. So Tetralogy of Flow. This one's probably the worst of them. There are 4 different defects going on. First you have the stenosis, or the narrowing of the pulmonary artery. You have the hypertrophy, so the overgrowth of the right ventricle. And you have the dextropositioning of the aorta, which dextroposition means move to the right, so it's in the wrong place. And then you have the ventral septal defect, so you have that hole developed here. So you have the narrowing, the hypertrophy, the dextroposition, meaning wrong spot, and then the ventral septal defect. So 4 different issues going on with this kind of defect. So signs and symptoms of Tetralogy of Flow. In the 1950s, these babies were called blue babies because that's what they are. These babies are blue. This is not one you're going to miss. They're blue babies. They have cyanosis that increases with age. The clubbing fingers, remember, because of that hypoxia to the fingers and the toes. That squatting position, because it feels more comfortable for them to squat so that they can get that blood flow back up to where they need it to be. Okay? They have failure to thrive. So these are going to be thin kiddos looking really kind of just sickly and gaunt. They can have dyspnea with exertion. Okay? Feeding problems, because remember, what do you have to do in order to eat? You have to stop breathing. You cannot breathe and take it and swallow food at the same time. So then they have problems feeding. They have frequent respiratory infections because they have to be able to, you know, they're constantly taking those breaths to catch up, and they can't catch up their oxygen, and they don't have the reserve that most people do. And so they get a lot of respiratory infections from food getting down there, or just not able to fight it off. And then they have your paroxysmal hypercyanotic episodes where they get really blue for a little bit, and then they get reoxygenated and they come back not so blue. But these kiddos, you're not going to miss these kiddos. You're going to see them and know that they have a problem very quickly. So like I just talked about, the proximal hypercyanotic episodes, it's spontaneous cyanosis, respiratory distress, weakness, syncopal might occur, which means they're going to pass out on you. Okay, I'm not a very good stick person. Known as TET spells. They're going to want to be in that squatting position. They occur during the first 2 years of life. They have episodes can last a few hours. The episodes are followed by lethargy and sleep because guess what? They just had, our body was just on freak out mode trying to get as much oxygen as it could. When you have somebody like this, you're going to place the child in a knee chest position. So like say, like, you know, you're basically putting them in that squatting position, okay? Because you want them to do okay. You want to put those knees up towards their chest. So if you're a mom holding a baby, you might have the mom holding the baby, and then she's going to put the baby with its knees up here, up on their chest, okay, so that they hold them with the knees to the chest. And that helps, again, get that blood flow back up so that they aren't wasting their oxygenated blood on their feet and their toes where they don't need them as much. So here's a picture of a kiddo. Maybe you can see a little bit of that discoloration in the legs versus the chest and the face area. But you can see that we definitely have our legs up as much as we can to our chest. You've got a parent holding them with their, trying to get those legs up as much so that, again, we're not wasting that oxygenated blood down in those legs where, you know, we need it, but not nearly as much as we need it, the oxygen to our heart and our lungs. Complications from tetralogy of flow. You've got your polycythemia, which means too many red blood cells. And so what happens when we have too many red blood cells? One, we increase the pressure more, but we also start having clotting issues because now we've got so many red blood cells. We've got things getting blocked up and causing problems. So too many red blood cells can be a problem, but at the same time, it's what the body has done to compensate for the lack of oxygen. It's made more red blood cells so that it can, okay, well, not all of them are going to get oxygenated, but at least some will, and increases the odds a little bit. They can lead to thickened blood and cerebral thrombosis, so, you know, in your brain, bad place to get clots. Can happen when clients are dehydrated. The other thing, we've got iron deficiency anemia, so now the body has used up all your iron to make more red blood cells, and now you don't have as much. But it's also used to decreased appetite because they just aren't taking in that protein. It's too hard. And then that bacterial endocarditis. Again, getting that, you have a weakened immune system and a weakened kid, that infection can take over, and once it gets around that heart or in that heart tissue, it's really, really hard for us to fight off. Diagnostics, we're going to do a chest x-ray. See, because you can see that heart. Here's a normal chest x-ray. You can see the borders of the heart, nice and kind of clear. Remember, the heart doesn't have any bones in it, so you're not looking for bones, but what you are looking for is that nice clear border of where the heart is. And you can see here, down here, we've got this nice, this really big area where that heart is. That heart's really, really enlarged. And so you know that they've got some sort of issue. They called it a boot shape or a clog shape. If you ever went to Holland and you know what the clogs look like. The other thing we can do is an ECG, or we can do an echocardiogram to look at the structures of the heart. So our treatments, what can we do for a heart that has this many issues? Our treatment goal is to increase pulmonary blood flow. We want to get blood to that. We want to get blood to the lungs to get help with that hypoxia. So our surgery is going to be temporary shunts to the newborn and preterm infants, and we're going to have open heart surgeries. These kiddos are going to have several open heart surgeries, looking at fixing as much as possible the lungs, getting that blood flow to the lungs. Treatment. More treatments, medications. We're going to use analgesics, morphine, because remember what we've learned about morphine. It decreases the respiratory drive. We want that. We don't want these guys struggling to breathe. We want to decrease that respiratory drive so that they alleviate some of the pain. Medication treatment is used to treat severe cyanotic clients until defect can be corrected surgically. Another thing that we might do is we might do some beta blockers. The propranolol relaxes the infundibular muscle so blood can move more efficiently from the right ventricle to the pulmonary artery. Again, just kind of relaxing those muscles to help open up and let blood flow more easily. Acquired heart failure is not actually a congenital defect, but it is something that happens due to congenital defects. It occurs after birth. It may be complication of the congenital heart disease or defect, but a response to a respiratory infection, sepsis, hypertension, or severe anemia. Heart failure is a decrease in cardiac output necessary to meet the metabolic needs of the body. So this is going to be, as the heart fails, what's going on, and the damage, the side damage, and the domino effect that happens to the body. acquired heart failure is going to have a lot of the same signs and symptoms. It's going to have fatigue during feedings because, again, that heart is not pumping effectively, so they are not getting the oxygen they need, so it's hard to eat if you can't breathe. All right, so you might have that fatigue during feedings, dyspnea, tachycardia at rest, might have some diaphoresis or sweating on the scalp or forehead. They might have sudden weight gain. And where is that sudden weight gain coming from? It's coming from like the fluid retention, because if we're not perfusing well, we're not perfusing our kidneys well. So then we're starting to go into some different organ failures from it. So if that fluid is starting to gain, if all of a sudden a mom comes in and she's like, my kiddo has just gotten really heavy and isn't quite, it's puffy and all that kind of stuff, that's sudden weight gain, again, from that heart failure. Labs that we're going to check, again, that BNP like we talked about earlier, anything above 100 says that we're going into some sort of heart failure. Then we might also do a chest x-ray. Why would we do a chest x-ray? Because with acquired heart failure, our heart starts enlarging because it's trying to pump. Bigger is better, right? Well, not so much in the heart, but it thinks that, and our body starts making the heart bigger to try and pump more volume. But unfortunately, our heart can only get so big in our chest cavity, and the muscle's not meant to stretch out. If you think about a balloon that you've blown up several times and you've blown it up bigger and bigger each time, eventually that balloon starts to lose its elasticity, and it never, even when you deflate all the air out of it, it never gets quite back to that same small size, right? It always stays kind of a little bit bigger, and it never gets back to that small prepackaged size. And that's what's going on with the heart. It's been blown up so much times over time, and it stretches out. It no longer has that good contractility that we need it to have. What are our goals for heart failure? Treatment goals is to reduce the work of the heart. So if we've got a lot of increased fluid, we need to get that fluid off, just like we do with adults that have heart failure. We've got to get that fluid off. We want to improve gas exchange, right? We want to improve that oxygenation, okay? The other thing we want to do is we want to maintain proper nutrition. All right, that eating, it's so hard for them. So we might be giving them some protein shakes, something like that to help get that adequate nutrition in there. We want to prevent infections. So we're going to talk to them about hand washing. I know it seems really lame to talk about hand washing, but this is probably one of the most important ways that we as nurses and healthcare team can prevent infections, is simply by washing our hands. We want to reduce anxiety of the patient, because when you're hypoxic, you're anxious by nature, but also the anxiety of what's going to happen and what's going to go on with them. And then we really need to support and educate parents, kids, family members, aunts, uncles, whoever is in that support team. We got to remember, today's day and age, man, parents aren't the only ones in the support team. In fact, sometimes parents aren't even in the support team. But we have to make sure that we're there giving support to all of the people there that need that support to get help for making this kid healthy and better. So your favorite part and mine is the pharmacologics for heart failure. So you've got your cardiac glycosides, which our biggest one is DIG, or digitoxin, digoxin, Lanax. I call it DIG. So you'll probably just hear me talk about DIG. It's preferred because it's rapid action and shorter half-life. It slows and strengthens the beat of the heart. So this increases the contractility of the heart. It does not speed it up, which we don't want. It increases that push and that contractility. You'll learn I can't spell very well either. For infants and younger children, we have to be really careful because their heart rate isn't like ours. If we have a heart rate of 60, man, we're doing pretty good. We've worked out, whatever. With kids, that heart rate gets less than 100. We have to hold that DIG, okay? Because with kids, with those little ones, infants and younger children, we need to make sure we're paying attention, because a heart rate of 60 to them is half of what it should be. Think about with when you did mom and babe, that was there was like 120, 140s, 160s in utero. So when they come out, they're down to 120s, 140s. You get down to 60. That's less than half of what their heartbeat should be for those infants and those little ones. For older children, if the heart rate is less than 70, we're going to hold it. All right. The other time that we're going to hold it is what we're going to talk about is DIG toxicity. If a kiddo is vomiting, we might need to hold it because that might be a symptom of that DIG toxicity, which I think we'll talk about here in the next few slides. Classic symptoms of DIG toxicity are yellow-green vision or halos around lights, which I'm not sure if Vincent van Gogh had DIG toxicity, but he did do a lot of impressionistic things with yellow lights in his paintings and a lot of halos around things, especially if you look at Starry, Starry Night. That has beautiful yellow halos. Who knows if he actually had DIG toxicity or not. But the nausea and the diarrhea, anorexia, irregularity in rate and rhythm of pulse, sudden change in pulse are all signs of DIG toxicity that we have to be careful with. But with kiddos, if they are vomiting, we need to check their DIG level, okay? And when we're checking DIG levels, it's whatever the doctor orders it to be, because we don't want to be giving them, if they're vomiting because they have a GI bug, well, we need to give them hydration and all that kind of stuff, right? But if they're vomiting because of their DIG, then we need to make sure that we're holding their DIG and all that kind of stuff. So families have to be taught to check that pressure, that heart rate, one, to make sure that it's above what? It's above 100 for little ones and above 70 for older children. Okay, so it needs to be above 100, and then we can give the DIG. But again, if they've got a heart rate above 100 but they're vomiting, we need to check at what's going on before we can give them their DIG. Okay, our antihypertensives that we have. We talk about beta blockers, which end in the -ol. So this is our metoprolol or labetalol and our propranolol. They decrease heart rate. They decrease the strength of the cardiac contraction, and they constrict the bronchioles. So we want to think about who would we not want to give beta blockers to? Our asthmatic patients. And think of how many kids have asthma, right? So we want to make sure our asthma or our COPD people, we're paying attention to those beta blockers, because we are now going to constrict their bronchioles, their lungs, because of the medication we're giving them. And remember, as nurses, our first job is to do no harm, correct? So calcium channel blockers, they block the movement of calcium into the cardiac and vascular muscles. Therefore, they decrease heart rate, right? So we're going to decrease that heart rate again. They force, which decreases the force of cardiac contractions. They dilate peripheral blood vessels. Okay, so think about that. So one of their side effects is flushing, because we've decreased those peripheral blood vessels. Examples of this are going to be your amlodipine, your ditalazem, and verapamil are kind of all in this area. Something that we always want to pay attention to with our antihypertensives is hypotension as a side effect, right? Because it's working too well or we've given them too much. Also, what comes from hypotension, the dizziness, the headaches, and lightheadedness. So we really want to pay attention to those things. Also, bradycardia, because if those heart rates get too low, we really don't want them taking some of these medications. Our ACE inhibitors, we want to pay attention to. They just prevent the converting the enzymes through. They end in pril, so your enalapril, lisinopril. So those are things, again, we want to pay attention to if their blood pressure gets too low. Angiotensin receptor antagonists, again, same thing, kind of things that we want to pay attention to is they prevent vasoconstriction in the response. So we want to make sure that we're paying attention to their hydration status, because it does mess with some of the sodium and water balance that they have. Examples of this are losartan or valsartan. can again cause some dizziness because of that risk of decreased blood pressure. If we decrease it too much, we've done a good job, but unfortunately, we still need some blood pressure, you know, to perfuse blood to our brain. Your alpha adrenergic receptor blockers, they block the constriction of arterioles, so they again decrease that peripheral vascular resistance, or that blood flow to the peripheral. Side effects, orthostatic hypotension, so you might want to get some orthostatics on patients that are taking this kind of med. Actually, on any of these, that wouldn't be a bad idea. Excuse me. They're best if they're taken at bedtime. Advise patient to lie down for 2 hours after these doses. So if we're taking some of these, let's just give them to them at bed. Examples of these are doxazosine and prazosin. So we've already talked a little bit about the ACE inhibitors on the other slide. Again, monitoring for that hypotension, because again, we've done our job too good. Watch for cough because of the effects that it has on our lungs. Renal dysfunction and hyperkalemia, that potassium climbing too much. Our diuretics, this is one I wanted to really focus on here, is our Lasix or your chlorothiazides, which are frequently given for hypertension. But your Lasix, something that we want to make sure with our Lasix is that we monitor for electrolyte imbalances. If we've already got some cardiac issues, the last thing we need to do is now mess up our potassium balance. Okay, so we really want to be watching our potassium that we're giving them. So you might be giving somebody Lasix, and then 20 minutes later or so, you're going to give them some potassium so that they can keep and maintain a potassium level, because Lasix are potassium wasting. They like to really it likes to really bump out our potassium. And what we know about potassium is it really likes the heart and helps our heart function at a normal level. So if someone's already having cardiac issues, the last thing we want to do is mess up their potassium levels. O2, 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 it's so important. We kind of need it to live. So we need to really pay attention with these people because remember, what their big problem is lack of oxygenation because of the decreased cardiac function, right? So we really are, a lot of these guys are going to have O2 on, and it's really important that we keep adults, we want above 90%, and kiddos, we want 95%. If I have a kiddo that's sitting at 95%, I'll be honest, I kind of watch them more closely because there's not much lower a kid can go. If a kid gets below 90%, we're in big trouble. Their brains do not take hypoxic events very well, and they have quick brain damage from low oxygen just for a moment. Whereas our brains, being adults, can handle a little bit less oxygen, and we can handle hypoxic events a little bit better than a kid can. So make sure when we're doing things like, transporting people somewhere, that we make sure that this tank is full before we go, or that our tubing is actually connected and working, or that, how about our tank is on. Those are all good things to make sure. They sound simple, but man, these are the things that get forgotten so easily. I used to transfer patients all the time from unit to unit, and it was easy when you had that many people doing stuff to forget to check your tank and to make sure the O2 was on and on the right setting. So things we're going to do for a kiddo that has acquired heart failure. We are going to organize cares so that our infant is not unnecessarily disturbed. That rest periods are so important. I think we as nurses and as a medical thing, we think we always have to be doing stuff, so that people are getting better because of the stuff we're doing. Man, our body heals itself a lot of times if we would just let it rest, right? Mom always said when you got sick with a cold, curl up in bed, sleep, it's best medicine. It really is some of the best medicine. So let's make sure that we're organizing our cares to keep, allow for those rest periods and not to be waking them up. We're going to feed early if crying and late if asleep. If they're sleeping, let them sleep, okay? I mean, that's just kind of an old parenting adage. You never wake a child, so, or a baby especially. But, you know, we want to give them some feedings. We want them to be small and frequent. I would even say probably high protein and high nutrition value. You know, you're not going to want to give them French fries and stuff like that. You want them to be quality meals. Oxygen administration to relieve dyspnea. Medications are given as prescribed after dosages are checked for safety. And with kids, double check. Always have someone help you double check kid meds, because they're so little, their doses are little. Make sure you double check them, okay? Accurate recording of I and O, all right? We want to make sure that we know what's going in and what's going out. You're going to weigh diapers if you have to, but really want that accurate. And then teaching the family to do that. They can do it. They're quite able to put a diaper on a scale and check it for you. But we really need to make sure that we're doing I's and O's on these kids to watch for that fluid retention. With education, we want to promote rest, right? We want them to heal. We want to have that rest time. Heart-healthy diet. Remember, speaking of eating good quality food, not just McDonald's and the fast food. And I know they're busy and they're exhausted, and you know they have 3 other kids and all this stuff, but we really need them to eat some heart-healthy diet kind of stuff. You know, it's good for the whole family if they can do it. Medication knowledge, dosage, and side effects. So what's the side effect of digoxin that we really want to watch for? Vomiting. If they're vomiting, we want to make sure we're paying attention to that, okay? Meaning that they don't give the medication. Or guess what? I don't give my medication because my kiddo's heart rate is less than 100. Okay, maybe they need to call the doctor and ask, but at least they're not giving it if that heart rate's less than 100. Or for older children, less than 70. Okay? Positions to promote oxygenation. So what kind of position is that? That's our semi-Fowler, right? So we're going to have our person on the bed in that kind of elevated position. All right? So that's the kind of position we really want them in to promote that oxygenation. If they need to, these guys aren't going to be the ones that squat as much like our other diseases did. So we want to make sure that they're in a position that's comfortable, but definitely that head elevated. This isn't a kiddo that you're going to want sleeping in a flat crib, right? Because that's not going to help them oxygenate. So maybe, you know, a swing or a bouncy seat or something like that to help encourage that oxygenation.